Hello friends, welcome to the part 3 of my lecture series on acute coronary syndrome. In this particular part, we are going to discuss the different conditions, the differential diagnosis which we need to keep in mind while suspecting acute coronary syndrome. And I'm going to discuss some parts on also the clinical features which we need to keep in mind while making a diagnosis of acute coronary syndrome and differentiating them from the other conditions. Looking at the acute part of this, acute myocardial infarction is one of the prime thing which we need to diagnose. Apart from that, angina or dissection of the aorta, this is another important condition which we need to keep in mind. Then tension pneumothorax, pulmonary embolism. Then there are some other causes. Pneumonia is one of them. Empyema, chest wall pains, which is another differential diagnosis. Sometimes you will get the patient with muscular pains, rib fractures, bony metastasis, costochondritis, pleurisy, GERD, pericarditis, and most important, anxiety neurosis, which is also a cardiac neurosis. In some books it has been written. All these conditions we need to keep in mind while we are making a diagnosis of acute coronary syndrome or acute myocardial infarction. If you look at the differentiation, how to differentiate between the angina versus acute MI. Both the conditions, the pain is retrosternal and it radiates to the arm or to the epigastrium, sometimes to the neck. And it is only the time frame by which you can differentiate in this particular two conditions, as well as the severity of the pain, which is more in acute MI compared to the angina. The angina is more precipitated by exercise, emotions, cold weather sometimes. Often in MI, there is no obvious precipitating factor. It is relieved, angina is relieved by rest or by nitrates, whereas MI is not relieved by any of these nitrates. Sometimes it persists. Pain is mild to moderate severe in angina, which is more severe in acute MI. Anxiety may be mild in cases of angina, whereas the patient is quite anxious when it is acute MI. Sympathetic activity is not increased in angina, whereas it is increased in MI. Nausea and vomiting is a feature more in the acute MI and less commonly seen with angina. If you look at the difference between angina and reflux esophagitis, although in these two conditions also they are the pain which is the retrosternal pain or the epigastric pain, precipitated again by exertion, which is more of the angina. Also in esophagitis, it is again worsened by the emotions. It is relieved by rest and nitrates, not relieved by rest. Sometimes esophageal spasm can also be relieved by nitrates. The patient usually often is awake in the night in reflux esophagitis. The heartburn is not related to angina, whereas it is related to reflux. And many times, if you see the history of the patient, reflux esophagitis, patient get more pain during lying down, which is relieved in the patient with angina. And duration, of course, is variable with reflux. These are some of the differentiating features between these two conditions. In looking to the pericardial pains, pericarditis, again the pain is retrosternal or radiate to the left shoulder, sometimes to the back. There are some prodromal symptoms like viral illness. There may be some sharp pain. There may not be any initial precipitating factors. Made worse by change in position and respiration. All these pains are relieved by NSAIDs, and there may be sometimes you find a pericardial rub which is associated with pericarditis. In dissection of aorta, whereas the pain is quite severe and it is between the shoulder blades and going to the back, and it is a tearing pain and it persists in spite of all the treatment, and sometimes it is very difficult to differentiate between the acute MI and the dissection of aorta. and patients may present to you with asymmetrical pulses. There could be bradycardia or a high systolic pressure. There may be a diastolic murmur. There could be a syncope. Sometimes it is also having some focal neurological signs like seizures and all. I remember one patient in which we could not make a diagnosis in the early phase, and then it was only the MRI scan which could produce the diagnosis of dissection of aorta. So the condition is very dangerous, and if not treated properly, it may produce fatal. Tension pneumothorax, on the other hand, is another condition which is a life-threatening situation. There may be a pain which is associated with the sudden onset of shortness of breath, the pleuritic pain, and patient may have a respiratory distress, tachycardia, tachypnea, hypotension, distended neck veins, trachea may be deviated away from the affected site. There may be an increased percussion note and decreased air entry, and breath sounds are almost absent on the affected side. This is again a life-threatening situation. We may have to put a needle in the second intercostal space. If there is a chance to get an X-ray done to make a diagnosis, otherwise it is the clinical diagnosis by which you have to depend and intervene as early as possible. Pulmonary embolism is another condition which presents to you with acute dyspnea, pleuritic chest pain. There may be some hemoptysis. There may be some cough with the pink frothy sputum. Sometimes the patient may have a syncope, and there is a hypotension, gallop rhythm, JVP may be raised. There may be a loud P2, which is the sign of pulmonary hypertension. There may be cyanosis, sometimes atrial fibrillation. Diagnosis of coronary artery disease, if you look at the all cascade of the things, the history is most important. You have to go into the history. There are different types of angina. I don't think I should cover that in this particular video. Unstable angina, resting ECG or exercise ECG as per the demand, we have to do it. There are certain investigations which support the cardiac scintigraphic studies, radionuclear scan, that is, by which you can make a diagnosis, or echo is one of the important tools nowadays. It is into practice all over the countries in a district hospital as well. The coronary angiography, CT angiography is a new tool which is now practiced everywhere. Cardiac MRI is the newest tool which is giving a diagnosis at a authentic level. I think this is enough for this particular video. I will see you in the next video again. Thank you so much.